Hello, my name is Marisa Arky. I'm a nurse practitioner and associate clinical director of telehealth at MedStar Health. I served as clinical lead for our COVID-19 remote patient monitoring program, and I'm honored to share this work with you at the 2023 summit. COVID-19 created an urgent need for the rapid adoption of telehealth, and RPM was a great solution. Health systems needed a way to redistribute care safely from the hospital setting to the community to maximize inpatient capacity while minimizing spread of infection. A large-scale RPM program was implemented at our regional health system for COVID-19 patients being discharged from our 9 emergency departments to support their treatment and recovery outside a traditional health facility. This was later expanded to monoclonal antibody infusion sites and inpatient settings. The program utilized digital technology to collect patient data from a remote site, often the patient's home, to drive care management. We included patients who are often excluded from RPM to minimize selection bias seen in technology-based interventions toward patients who are primarily English speaking, of higher socioeconomic status, and technologically literate. A retrospective observational study was conducted between December 2020 and August 2021 at MedStar Health, a not-for-profit healthcare system in the Mid-Atlantic region that included patients from all 9 ED sites. Patients were consented, provided a pulse oximeter, and enrolled at discharge. Participation was insurance blind and free of charge to the patient. The study describes the methodology of deploying the program and quantifies the patient and program characteristics. The primary outcome is a descriptive analysis of enrollees, including total number of patients, age, gender, and racial distribution, vital sign trends, and number of days of engagement per patient. Secondary outcomes include analysis of RPM versus non-RPM groups as related to 30-day returns to ED and ED diagnosis and disposition at return visit. The RPM team was comprised of nurse practitioners and medical assistants. The team captured vital sign and symptom progression data over a 16-day monitoring period, engaging patients via phone, video, and chat within the platform. Abnormal vital signs and concerning symptoms like chest pain or shortness of breath were flagged with escalation to in-person care and return to ED when appropriate. This is one of the largest COVID-19 RPM programs to date with physiologic and symptomatic monitoring. Our findings suggest that RPM helped appropriately guide sicker patients back to the ED who needed escalation of care and allowed patients to stay home who did not require return to acute care. Feedback from patients, families, and clinicians was overwhelmingly positive. While RPM and other telehealth modalities can increase access to care, they can inadvertently widen disparities. Technologic and medical fluency was a factor in enrollment and participation. 120 patients did not own a smartphone, and the team dedicated additional time and resources to calling these patients daily and performing manual data entry. 43 patients spoke a primary language other than English and engaged with the team utilizing the assistance of Bluestream interpreter service. Participants were distributed widely across the metropolitan Washington, D.C. and Baltimore regions, including rural geographies with lower density of medical access. The study has limitations. This is a non-matched retrospective observational study, and patient enrollment was not blinded. There was opportunity for bias in enrollment due to many confounding variables, and patients who followed up at another health system were lost to follow up. Lessons learned along with clinical and operational workflows can be applied to RPM for other acute disease states, such as pneumonia, acute decompensated heart failure, and COPD exacerbation. It is imperative to consider health disparities and equity issues and have a plan to address them. We can also anticipate for any future COVID-19 ramp up and plan for capacity management. In summary, RPM is a versatile tool to expand our scope of care delivery. Inclusion criteria, platform selection, communication modality, and methods of data collection significantly impact patient participation and experience. This study can be used as a building block to continue exploring functionalities and clinical strengths of RPM. If deployed conscientiously, RPM and other telehealth modalities can be powerful tools to fill existing holes in healthcare accessibility. Thank you so much for your time.